I also am a professor in the chiropractic college. I teach their postgraduate students. Every class I teach these methods. Every class tells me that every class of postgraduate, they all tell me that they have been able to integrate this and find it useful. My daughter's a chiropractor. She also teaches with me in the chiropractic college. She uses these techniques on a daily basis in her practice as a chiropractor. These are techniques which are very accessible to you. You can't do just anything in behavioral therapies, but there are some that are very accessible, very useful, very applicable, would probably help you a great deal. Dr. Goodfellow and I are going to go over that. Please come up. Now, what I'm going to do here, first of all, is just go through something called an applied relaxation technique. We're going to do it together, and I'm going to, first of all, explain what I'm doing to you, have you practice a little bit how to get into that. I'm going to show you how it's done. Dr. Goodfellow is going to do it, and then I'm going to ask you to do it. How many here would like to learn a technique you can all use? Okay. What you'll need to do is, once we're done here, just pair up with somebody sitting next to you. Turn your chair so you're facing each other, and you do what I did. And then have the other person do it with you. We're going to spend about 15 minutes or so of this first part of the meeting doing exactly that. I'm going to do it. I'm going to show you. You're going to try. Behavioral therapies. Can you hear me? Behavioral therapies such as cognitive behavioral therapy are the most studied, and we have the best evidence for them. There's little to recommend one type, one religion of psychological therapy over another, but the behavioral therapies and the relaxation therapies are important in the management of recurrent pain, and there's an excellent review and quality journal there that gives you the data on that. What all of us should be doing, what you should be doing, what I should be doing, every time we see a new patient, based on the bedside history and exam, we have to look at what are the probable mechanisms of the pain, what are the functional problems. And we need to ask ourselves three things. What is the character of the pain, and is the mechanism likely susceptible to pain relief? That's what you do when you're doing your equilibrations, and when I'm doing my injections, and when I might be doing my manual therapy of somebody's neck. We're treating the pain mechanism. Psychological or medical comorbidities are present in many people, and can these be relieved? This is what you're addressing with the technique that I just showed you. Problems in coping and functioning, and case management, can that improve things? The relaxation and behavioral therapies can also come into problems in coping and function. This patient came to me a little while ago, been managed by management in the community, trying to get him back to work, basically, and he was getting into panic attacks every time he went back to the work simulation. And he would huff and puff so much that he was groaning on the breath in and groaning on the breath out, and that's no exaggeration. He was stiffening up, and he was jumping from foot to foot, literally like that, and they couldn't do anything with him, and they sent him back to me and asked what to do. I began to do this with him, and I told him all the way out of this clinic now, all the way out, every time you breathe out, you tell a body part to relax. Well, the panic attack stopped. I saw him again this week after 6 weeks hiatus. He hasn't had a single panic attack in the last 6 weeks. He's back in therapy. He's been able to finish the physiotherapy part of it. He's now working with a psychologist, and he's working on getting back to work. So this sort of thing can be very useful in re-engaging somebody in rehab as well. Earlier than the estimated sleep time. When the alarm awakens, have the person set the clock, then half hour later until achieving stable sleep time when the alarm rings half the time for him. And if unable to get to sleep due to restlessness, have them leave the room rather than roll around in the room and be upset in the room. Don't let the room be aversive. Don't use TV or light sources or entertainment sources in the bedroom. Have them sit somewhere else in the house with the lights out until they calm down and go back to bed. No napping to catch up in the day. Once it's initiated, you can try things like sublingual melatonin if sleep onset's an issue. Psychoeducation for pain can also be used, and it's important to identify useless versus useful pain and go over the notion that no pain, no gain is a really lousy philosophy when you're helping people with chronic pain. It should be Useful pain, not useful pain, how can you manage that better? Multidisciplinary pain management, not very accessible to most of you. I do that, but you need to have specialized clinics, special funding to make that happen. They usually include